Welcome our in-person and online participants to the Endometriosis Mics Are Open event. We're thrilled to have you here. Let's kick things off by introducing our amazing endometriosis excision specialists, Dr. Yamal Patel and Dr. Njagi. The reason why I keep saying they're amazing is because they're patient-focused and very patient-centered when it comes to endometriosis care. Let's get this rolling and dive into it. Welcome, docs.
Thank you. Thank you so much. Thank you. So it's good to be here. Right. So I think welcome everybody who is online and on site. I think let's get discussing endometriosis.
First and foremost, thank you. I know you both have had a very busy theater day today, and we just wanted to do this event. Basically, you know, we always have events that are centered around presentations and doctors giving their presentations, advocates giving their presentations. This time around, I wanted this to be an opportunity. Well, we wanted to be an opportunity where patients online and in person can ask you questions, because we know consultations are very expensive as well. And we wanted to have this in the month of March. This is the one event that we all agreed that we'll do this and take it from there. So I am Arti Shah. I'm a patient advocate. I've been battling endometriosis for over 25 years. So I don't need to ask questions because I have them at hand. Let's start rolling out questions.
Yes.
So how will you describe like endometriosis pain like that? When should I feel like it is this pain is endometriosis pain?
All right. So the question that has been raised by one of the participants here is, how would I know that this pain that I might be having is endometriosis pain? And I mean, my response to that would be that pain is a subjective feeling, and pain is something that is a response of the body to some sort of stimulus that is not good or acceptable to the body. Now, we can't say that this pain is specifically endometriosis, but what are the hints to those kind of pains? If you are having pain in any different part of the body that exacerbates during or around the time of your periods, then start thinking about it. If you have pain that is there starting in that fashion, but then over time becomes chronic, it's there all the time, think about it. If you have pain that is centered around ovulation, you may need to think about it. If you have pain during passing stool, especially worsened during periods, think about it. If you have pain when you have sexual intercourse, especially not at the entrance, but deep inside, and it might be sometimes in certain specific positions, think about it. So when we say pain, we mean pain that is specific to around the period times, worsened at that time, but it could be continuous pain as well that becomes chronic pelvic pain. And it's difficult to make a diagnosis of endometriosis only on pain. So please do not make that mistake. But what that means is you will specifically need to now seek advice from endometriosis specialists and centers for that kind of an evaluation. Do I have endometriosis or not? Anything you'd like to add to that?
Well, I would say, I think you've just put it clearly. And also, first of all, really welcome everybody on board. And it really gives us a great pleasure to be here and talking about endometriosis. And what a better time to bring awareness on endometriosis. And for me, It gives me such a great pleasure to share the same stage with Yamal and Artie, um, with whom I think a lot of work is happening around endometriosis. I think we know that the symptoms for endometriosis is basically pain, and when we talk of pain, I think it's basically what Yamal has mentioned. As long as you have pain that you're aware of, and pain that is affecting your normal function, or it's affecting your quality of life, I think that's pain that should be taken seriously.
Great. Anything else? Any other questions?
Yes, we have another question right there.
Yes, my question is, what are the big causes and risk factors for
So what are the main causes and risk factors? You want to start taking that?
Well, I think that's a very interesting question. And just to kind of put it clear, is that endometriosis has gotten all kind of descriptions. One of them is a disease of theories and enigmatic disease. It's still not very clear. Of course, now research is kind of steering us the right direction, but it's still not very clear with certainty that we can be able to with certainty say how endometriosis really developed. But then there are beliefs that we've believed previously that causes of endometriosis, and now with more research and more studies and more presentation, we're actually finding that there could be possibly what we knew earlier might not exactly be what we know today. Now, for instance, what do I mean by this? We've talked about endometriosis as different, supported by different theories, which can be immunological, they can be genetic, and so on and so forth. And what we really find as a challenge to really find is because what we felt, or what was previously thought, that endometriosis was a disease of patients who are in their reproductive age, actually it has been found it's not entirely true. And the reason is because we found endometriosis has been taken in biopsies of fetuses. So that means that these tissues were actually present even before delivery. And what we actually know, it's only they're activated, during the, the reproductive period, whereby now hormonal influence really plays a major role, mostly in development or growth of endometriosis. So we cannot really say there's one way that we know for certain will, is a cause for endometriosis. And that's the reason why we'll go back and find that now even prevention, because if we understand in not only endometriosis, any disease, if we know how the disease developed, then we are able to really have ways to prevent it from happening. We can give vaccination for the disease, and even the treatment becomes much easier. But this is not really what is found in endometriosis. So there's still a lot that we are still, science is really helping us to develop. How does someone develop, diaphragmatic endometriosis and they have very little of pelvic endometriosis? And this is where now we are finding what we believed previously, like retrograde menstruation, which was one of the theories, has actually been refuted by the findings that we are getting. So I would say there's still a lot of development that we're finding with endometriosis. And trust me, the moment we really find and for certain we know this is how the disease developed, then it's going to be very easy for us to manage endometriosis. I don't know what.
So I think causative, he's covered very well, and there's no specific cause that answers all questions. But I'm going to move a little bit into risk factors. So what are the risk factors? Some of the risk factors that have been known are some sort of uterine abnormalities. So if someone is born with certain kind of uterine abnormalities where the outflow tract could be abnormal, they would have a higher risk of endometriosis. So when you see a very young girl who's just started periods and within 6 months is in excruciating pain, look for endometriosis and look for a uterine anomaly, okay? Secondly, another risk factor is early menarche, which means if you start your periods too early, nowadays you're seeing this happening. Young girls as young as 9, 10 years have started periods. Well, that very early period onset could be a risk factor. Another risk factor could be delayed fertility. So in the olden days, our grandparents' age and all, by 17, 18, some of them had started having their children. With nowadays, we're seeing delays, and these delays are coming in with newer challenges like endometriosis sometimes setting in, fibroids setting in. So these are things that we're seeing with delayed fertility. Another risk factor would be environmental. There are lots of environmental factors that we still don't understand that actually are leading to more and more endometriosis being seen in these young women and girls. Smoking is a risk factor, right? That's been known. So what I'm saying is these are known risk factors, and there are many things that are probably still unknown that will still come up as we move and get more research into this field. Okay.
Definitely, even as a patient myself. I mean, there are a lot of like even things like products that you apply topically, that you internalize. Everything has a massive, massive impact on
We are still learning.
endometriosis.
So yes, this change of modernization is actually coming in with its own new world of diseases that we are now seeing, which wasn't there in the earlier. So the preservatives in food, the kind of all those things come with, none of them come without some sort of challenges.
Absolutely.
So we'll see.
Maybe just in addition to what has been mentioned, it's a question that we get a lot, or I get a lot. I'm not sure if Yamal, you get here. There's patients come and say, why is it that now we are seeing more cases in endometriosis than previously we were seeing endometriosis? So I still feel that I'm not sure if it's we were there are new cases for endometriosis, or now we are more aware that diagnosis has improved and care has improved. Some of the barriers and the challenges that we patient had in accessing care for endometriosis, I think is also improving. Of course, the lifestyle has changed, and fertility basically has changed significantly. But also, I also feel that women are more empowered than previously they were. And the challenges that we are seeing surrounding menstrual health and the taboo surrounding menstrual health, I think is reducing as time does go by. So women can actually come up and talk about their menstrual health. And majority of us now are really agitating about, hey, let's sit and have a conversation about menstrual health. I feel that there's a lot of work that is now going on, and I think here in Kenya, there's so much conversation we are having on endometriosis, and I see the same thing globally. So I'm not sure it's now because I'm right in the pool of endometriosis that now I'm more familiar and aware that there's a lot of conversations going on. Is it actually there's lots of conversation, but I think there's a lot of conversation that is going on surrounding endometriosis. So there's a lot here.
7 years, we've made a lot of noise.
Exactly.
As advocates, we've made a lot of noise, and it's amazing to see that in this whole train ride, the medical professionals who we need, especially a big handful, not all, there's still a long way to go, are in the cabin with us and the forefronts.
Right.
So thank you.
Right.
We have questions online as well. So I'll take a break from our in-person and start our online questions as well. We have Wanjiru Karuri, who's asking, how do you deal with endometriosis that one has had for over 20 years?
So thank you for the question, but I think I would say that is a very common scenario that we see. The endometriosis delay diagnosis is actually a a major battle that we are now fighting. We are trying to reduce the interval between initial presentation with whatever symptoms they are to actually label the diagnosis saying that I think that is endometriosis. So how do I deal with it is a different scenario, because the length of duration of the disease doesn't decide the treatment options. It's the involvement of the different areas and the extent of the disease and the symptomatology and the patient preference. So let's be very clear on one thing. Treatment for endometriosis is actually preference-based. It's tailor-made to each individual, and it is goal-based. So people come to us with different goals. Some come to us because they're trying to get pregnant. Some turn to us because they have severe pain. Some come to us because it's affecting their family life, because it's actually not allowing them to have a regular, marital life. And some come to us because it's now messing their mental status because of the stigma around it and the workplace and the whatever. So the goal decides the treatments, not the duration, but it's a very normal thing for us to see of this delayed diagnosis. So for her, if she's known for 20 years, then, I mean, that means that she's probably had it even longer, but she was diagnosed 20 years ago. I mean, that's how I would think about it.
And there are a lot of factors that play a role to you as well, Njiro, based on which doctor you saw, whether how long you've been dismissed, have you been misdiagnosed, are you now currently seeing the right doctors? Because we all know the story. Our journeys are all very similar with a different roller coaster rides of heights and lows. But again, it depends. Who are you seeing? How are you getting treated? Where are you getting treated? And if your doctors know endometriosis.
Yeah, I think just in addition to the question, and it's something that we hold conversation, but this is also what we see. Give an instance, patients I saw today, history of symptoms suggestive of endometriosis for more than 10 years. And well, it has worsened over years, and you'd make an assumption that she possibly would have advanced disease. And this is the fascinating thing about endometriosis, that it still baffles us who see endometriosis. So it's an assumption that you'd make and think that the patient who has this, long duration of the symptoms would have advanced disease of endometriosis. Unfortunately, it is not exactly what we find. And we actually find here she has symptoms suggestive of endometriosis. And when you do the imaging, you really find she really has subtle disease. But then this is the other thing that we also find is that the extent of the disease, how advanced the disease is not directly proportional to the patient's symptom.
Yes.
So in this case is you find a teenager who has possibly, let's say, early disease of endometriosis, has excruciating symptoms. By this, I mean pain and so on, as compared to somebody who has advanced disease who would not have that severity of the disease. And this is what is sometimes misleading. Then you'll find, let's say, this 20 years and, they have early disease, but then you'll also find somebody who's had symptoms for the last 5 years. You perform ultrasound scan and you find, oh my goodness, they have really full-blown endometriosis affecting different organs. And this is the reason why I think it's important that patients need to be seen early as possible. And I think Dr. Yamal touched on this. As much as we might not really clearly understand endometriosis and how it develops, and we have the risk factors, is we can shorten the period between the onset of the disease and time for diagnosis, because this can have significant outcomes on the patient. So again, to the patient who asked it, it really does not, I think the time, other than really the affected quality of life and possibly fertility issue that can come with it, it does not necessarily mean that they will have advanced disease now affecting different organs. And this is what we really find when we do surgery, we find certain changes that really can tell us this is old disease. For instance, when you do a scope, you can see the changes somehow looking white in color, blue, black, and so on. That really tells us. So the disease can be there for a very long period of time. But thank God for these patients, the disease has not advanced. But the earlier we get the disease, because we don't know, we cannot really tell that this is a patient that will progress to this severity, and this is the rate of growth. This we really cannot be able to tell.
I'm glad both of you mentioned that, because for the last few years, as advocates, we've been moving away from stages of endometriosis because they don't fit the circle anymore.
They don't fit the symptomatology.
Exactly, that's
They
it. And you said that in your videos that you're doing, which are amazing. So thank you for doing those. And if you don't follow them, make sure you follow them because you learn a lot. Okay, we have another question from another one, Jiru, saying, oh, is it the same one, Jiru? No. My first period after surgery was extremely painful. It felt worse even before the surgery. Was that normal? Sorry, this is from PM. And Wanjiru has continued asking the question to follow up. Then also, how do you deal with PCOS and endometriosis in terms of medication and etc.?
So we'll start off the one with the post-op pain. Well, two comments there. Number one, the first periods after an endometriosis surgery, which might involve other surgical areas as well, can still be painful, and actually sometimes more painful because now you have an area that has been cut and it's healing, and now you get the cramping. So I even tell some of my patients, when you've had a uterus with fibroids and we cut the uterus to remove fibroids, now you have stitches there. And then in 15 days or 20 days, she gets periods and it starts cramping, because that's what the uterus does. It cramps during periods to push out the blood. It's like I have a cut here and I'm going to start doing this over the stitches. It's definitely going to hurt more. So the first period can be more painful following a surgery. And hopefully if an adequate surgery has been done, ideally speaking, the period should start becoming less painful over time. And then if the goal is fertility, then obviously there is no other role for immediate medical intervention. But if the goal is pain, and now they want to make sure that the recurrence rate is lowered, then they could go on some sort of medical suppression as well. So the first period or the first 2 periods after a surgical, an extensive surgery on the pelvis can be a bit more painful than the usual.
And it also depends on location, right? If you've had a bowel resection, if you've had like my first period after the excision surgery, because I had my left fallopian tube removed, was really painful.
Yes.
But then over time, it reduced, as you said.
And many times an endometriosis is actually associated with adenomyosis.
Absolutely.
So adenomyosis is a bigger culprit in terms of treatment, because it is much more difficult to excise since it is within the muscle of the uterus. And if you excise too much, you don't leave a uterus. You leave half a wall out and the other wall is not there. So that's a useless uterus, which we cannot afford to have if someone is thinking of future pregnancy. So adenomyosis can be something we have to look up in this kind of patients who say, my periods actually are still as painful, and someone has done an endometriosis surgery, you see.
And I just want to comment on that before you go on it, because I'm living that right now.
Yeah.
I'm living that fully right now with my cycles being
Still
missed
painful.
up, like they're 62 days delayed, 15 days delayed, and the periods are so painful. I thought endometriosis was a demon until endometriosis was excised and adeno was put on the forefront of the demoness. So yeah.
True.
Anyway.
No, I think I agree. With what Yamal and is putting across here is the pain that you get during endometriosis is a lot of inflammation that is going on, or changes and so on and so forth. So when we perform the excision surgery, it's basically you're really cutting out this tissue, and so you have a different form of inflammation that is happening after surgery. But I think there's also something else that we're finding, which I think is very important, and this is also uh, you have structures around where you've cut, there are muscles and so on. And because of this tightening of the tissue and the healing process, it's just like any healing of any part that you have surgery, for sure. You're going to have this process of healing and, getting better. And sometimes you can have this cutting of the tissues, taking place. So we're really finding that during this healing process, it's important to be aware. And I really think this is something that we've made some really great progress over the last few, months, years, is that not only are we excising endometriosis, but then we having our physiotherapists, not only who understand Kegel's exercise, but who really understand the pelvic floor and the healing, whereby it's not only tightening the muscles, but also how do you relax the muscles during the process of the healing. Because if you're having this cutting, as you mentioned, taking place, and then you're coming and now you're tightening the muscle, what is that going to do? It's just going to make the situation worse. Then also patient, taking this much time being immobilized, then the moment they start being active, then, the pain is coming back. And oh my God, you really find that I had excision surgery and now the pain is different and so on. So this, it can really be all these factors. And then when it comes to scarring, we all don't scar the same way. There are, patients who will have more risk of scar formation as compared to other patients. So all these factors have to be considered, and it's important to put the right context to the story and the healing process. And this is where now the conversation between you and your doctor is very important. Not that somebody went in there and just got some disease out, but exactly what was done, how much, how is my healing process going to look like? What am I supposed to expect? What do I need to be careful, about? What are things that I need to do differently? And this is where all these now, the journey, the healing process, it's a little bit, can be a lengthy one from patient to patient. And this is where, patient would really require support and so on. But in most cases, yeah, this, patient need to also understand that the pain kind of gets better as time does go by.
And the second question was, I think, polycystic and
Endometriosis together from 1-0.
yes. So I think that combination is seen in a number of patients. It's not the most common combination, but we do see it in some patients. And if they are both confirmed diagnosis that there is endometriosis and at the same time there is the polycystic ovarian syndrome, what is PCOS in simple words is a hormone imbalance in which there is some sort of changes due to the ovarian structure, in which the hormonal profile alters, giving these women challenges like irregular periods, usually delays, challenges like poor ovulation or not very regular ovulation. So they have irregular or anovulation. They have issues with weight. They have issues with hair being a little excess on the areas that it shouldn't be in women. They have issues with acne sometimes because of some androgen increase in their body. And they have issues with fertility, because if you don't ovulate well, how do you get pregnant? So you can't predict your ovulation, you can't predict your fertility. And then they have issues which are metabolic in nature, related to maybe future diabetes risk, or future blood pressure risk, or future cholesterol risk going higher. So that forms a combination called metabolic syndrome. So you have that as one angle, and then you have the pain and the endometriotic lesions on the other side. And when these two things come together, and you want to handle them medically, then most likely this is going to be hormonal treatment. So you'll have to go with some sort of a hormonal treatment that suppresses endometriosis, but at the same time does not allow the polycystic ovarian syndrome to keep on propagating itself. So I think some form of combined hormonal treatment, including both estrogens and progesterone, might be a good option. Even progesterone only options are good because it will keep the woman protected against the ill effects of unopposed estrogen, which happens with polycystic ovarian syndrome. So some sort of medical treatment involving these hormones might need to be considered in such a woman.
She's also gone ahead asked if PCOS and endometriosis cause ovarian cysts.
So polycystic ovarian syndrome is not actually cysts in the ovary. That's what many people come and say. I've been told I have many cysts, but and it's a misnomer. Polycystic does not mean many cysts. Polycystic is a certain morphology of the ovary where there are many follicles and they don't mature regularly, because normally you would recruit, you'll start off with 2, 3, 4 in each ovary, and then one takes over by around day 7, 8, and then it matures and it releases and ovulates. In PCOS, you'll have 10, 12, 15 of them growing, none of them maturing, none of them ovulating. So the patient gets a lot of estrogen production from all these small follicles. And because they don't ovulate, they don't get progesterone. And because they don't get progesterone, they don't get a regular period and they can't get pregnant. And they have effects of this estrogen excess in the body. And they would get a withdrawal. They don't get a withdrawal bleed, which is the period, but they get a breakthrough in between. So they get irregular periods. So basically speaking, they are not related to cysts. All right. Endometriosis could be an ovarian type of endometriosis which has a cyst. That's different. Polycystic does not have cysts. It's just many follicles, but there are cysts that can happen to anybody. So these are not specific to cysts. Okay.
S has asked, hi S, how do you deal with endometriosis that doesn't show up on scans, but the pain is horrendous? The million-dollar question that when patients are dismissed because imaging is normal, imaging is clear.
Well, now, so I before answering this question, I think we need to put things straight. Number one, it does not mean that pelvic pain is endometriosis. So that has to be very clear. And that's why we say symptoms suggestive of endometriosis. And you need to confirm that there's endometriosis. So what we know for a fact is that currently, previously we knew the gold standard diagnosis of endometriosis was laparoscopy, introducing a scope in the belly and, you're able to visualize the endometriotic lesion. And still, we'll still say that for you to confirm a diagnosis, yes, you need that, and you need a tissue, and then you need a histology to confirm the diagnosis. But now we actually know with the right skill, the right hand, and the good experience, and of course the right ultrasound scan machine, you can pick much of endometriosis. So we are now shifting more to picking up endometriosis. And now, in the event that you did not pick up endometriosis, this is my assumption. So certain things have to be standardized for us to really answer this question. So what do we need to be standardized? Number one, who performed the ultrasound scan? Is it an expertise who understand endometriosis, look for endometriosis and has a track record of picking up endometriosis? And this is something I sometimes find fascinating, is even when you have radiologists or radiographer who routinely do these tests, they need a feedback. Okay, so it has to, and that's why we say a multidisciplinary team. So, okay, fine. This is what I found. You went to theater. What exactly was it? So that, in addition, will help improve the specificity and outcome of picking up endometriosis. But in most circumstances, this is exactly what happens. And I was discussing with somebody today, what are the possible missed points when you make the diagnosis? So fine, patient comes to me today, you have symptoms suggestive of endometriosis, prescription, go and have an ultrasound scan. I don't really tell them where to go to have the ultrasound scan. So you will go and find the next guy in the block who is actually affordable. Now, affordable is something that is, and he said, okay, fine, no problem. I can perform an ultrasound scan. So he does an ultrasound scan. And in most cases, ultrasound scan is done, not really sure. He does not look at the history. Then a report has to be done by somebody else, or the reporting has to be done by somebody else if it's an MRI. And then the report has to come back to me. Now, you can imagine all that route. There is no way there has been any communication between me and the person who is actually performing the imaging. So what are you looking for? What is your clinical suspicion? What are you suspecting? Where should I look out for? So that communication has to be there. Now, going back, how can we improve this? So now when I say standardized, it has to be somebody who's performing routine ultrasound scan for endometriosis, and their protocols and their certain standardized way of performing endometriosis. And you have a track record. So now, assuming now from the question, this is somebody who has actually, in this, so has the right skill and so on. Even in that situation, if there's no endometriosis or changes from the ultrasound scan that can suggest this endometriosis, you still cannot rule out endometriosis. And this is a point where I have a huge problem. Is whereby so first of all, it's not standardized. It has been done by, somebody who possibly not routinely performing scans for endometriosis. It's returned back to me as the primary care provider, and I'm going to use this piece of paper to dismiss the patient's symptoms that, hey, look here, you don't have endometriosis because the scan says you don't have endometriosis. All right, wait a minute. Let's figure it out here. So between the ultrasound scan and me who's living the symptoms, who should be dismissed? Unfortunately, the patient get dismissed. And that is unacceptable. We gotta say it as it is. So now, what does that therefore mean? So if, for example, Yamal, myself, we perform our own ultrasound scan because the more we have this gap, the more points of missing out. So we perform our own ultrasound scan because I know from the patient symptoms how they're presenting, and we perform these surgeries. This is possibly what we are going to expect. And more importantly, it is the window. I call, this imaging is a gatekeeper that is going to help me to make decision on what we are going to find when we go for surgery. No surprises when you go for surgery. You cannot go for surgery expecting that you're going to find a small nodule and then you find a rectal nodule. That is really not acceptable. So in patients who have early disease, and this we call superficial disease or peritoneal disease, early disease, I should call it. Again, as you mentioned, we don't talk about stages because really, I still don't understand what really the staging of the disease really means. In some circumstances, you can still have that not be picked up on endometriosis. So therefore, this is what we say. If a patient has had imaging that has been negative or not changes, it's a good thing because now you're able to kind of tell that you're dealing with maybe minimal disease for us who perform these scans, possibly peritoneal disease. But then that does not still mean that you dismiss the patient. So if the patient has not responded on medical treatment or whatever option of treatment, then you sit and have a discussion with the patient and say, hey, guess what? We can still pick up disease on laparoscopy, which was missed on ultrasound scan. So those patients then will be candidates for diagnostic, not only diagnostics, but therapeutic laparoscopy for endometriosis. In most cases, we'll go find a really small, tiny node. Remember what we said initially, that the level or the severity of the disease has nothing to do with the patient symptoms. So if the imaging is negative, we have to be sure who did the ultrasound scan what are their expertise, and so even in that, where it was done by somebody who's an expertise, then this patient might require to have a scope.
Good. Yes, I think specific to the question, I think that covers most of my points, but specific to the question, ultrasound or imaging, whatever it is with MRI, normal, and this is a very common scenario we see. Number one, have a repeat imaging done with someone who does this regularly. I would say more than in my clinic, more than 60–70% of the cases, I might still find something. So that's one. So it rules out that was not normal, there is something. If we also still don't get something, which is also still possible, there might be very subtle findings. So what is subtle findings and what is normal findings of endometriosis? Subtle findings will not be picked up even on an MRI, but subtle findings can be picked up on an advanced targeted transvaginal scan. Okay, and what are these subtle findings? There are things we call site-specific tenderness and something called ovarian mobility. So a subtle finding of an ovary not able to move when we are sliding it from the uterus is enough to tell me this is possibly endometriosis when there is nothing else that has been seen. Okay, a subtle finding like a specific spot that I'm pressing and the patient is jumping and saying, no, doc, stop there, stop there. To me, I tell them, I'm sorry for the pain, but that's the specific area you would actually want me to assess better because there's something there that's making you feel the pain. So don't take that pain negatively right now because that's the specific spot I am keen on. So these two subtle findings can still tell me there's endo. So step one, have it done, repeat with an advanced center that does this. If we still don't get anything, no tenderness, no mobility issues, no nothing, it doesn't still rule out endometriosis. Right. So these are the very specific cases that we would say, all right, then, can we consider a diagnostic laparoscopy? And in this diagnostic laparoscopy, if we do find anything, we will correct it at the same time and excise the lesions when we find them. And we expect, if at all anything to be found, it would be superficial peritoneal disease. So that diagnostic laparoscopy comes in there. But I can tell you, Aarti, for a fact, over the last 2 to 3 years, I may have done only 2 diagnostic laparoscopies. So what I mean is, I don't use that as a tool to diagnose anymore. Absolutely. But it may be needed sometimes, okay? So only 2 or 3 in a whole 2 years is a very small number. These days, I only do laparoscopy for therapeutic, whether it's a fibroid. I already know what is there and I am going in to correct it. So it's operative laparoscopy, but there is still that role for diagnostic laparoscopy. So that's where that will come in to eventually say, imaging negative, this negative, examination negative, laparoscopy negative. Now we look at other possibilities of pain, okay?
Well, that's only also because doctors like yourselves and a handful in the world who do the mapping and imaging yourself.
Yes.
Okay, and this is the thing. I was diagnosed with endometriosis in 2004, having multiple surgeries. I finally did my excision surgery in India. Okay, here, my MRI, my imaging was completely negative.
Yeah. Yes.
But this is as advocates, we keep saying to patients, be educated yourselves, be empowered yourselves. If you feel a doctor has dismissed you because your imaging was negative, it's okay. Actually, it's not okay. Yeah. It's necessary to go to an expert.
Have it checked, yes.
Have second opinions, third opinions, however many, as long as you get to the right doctors. I'm pointing here because I know I've seen the difference in all my years of battling with endometriosis. I didn't even know I had adenomyosis until you told me about it post-surgery. And this is the battle that us as patients fight every day not knowing what's going on, because we are meant to trust our doctors, right? And this is the thing. I realize the difference the way you guys do my transvaginal scans. And I say that because of it's necessary to speak about what kind of scan we're doing. When you can't see anything topical, you told me we do a transvaginal. Okay. And this is the thing. The way you navigate, the way you explained it to me, the way you showed everything, the way you moved your probe or whatever it's called, compared to me going to a normal radiologist or a sonographer who has been referred to for me to go to by my gynecologist or doctor or whoever it was, and the things were negative, I was told that, okay, fine, you're whatever you've been doing holistically is good. So it's okay. Had I not known where my pains were and what I was going through, I would have come back not having an excision done. So yeah, I completely agree. So this is it. The core is going to doctors who know endometriosis and who do the scans themselves.
Well, well, thanks, Artie, and you know, and I'm glad that your experience, but sometimes what we do is we need to step out of our seat as the providers and look at it from the patient's, window. So fine, we'll sit here and we say we are endometriosis, experts or specialists, excision, and that's cool talking about it. And there are possibly many who still would consider the same. But I think one of the challenges that we need to address, and this is something I think I remember talking about today, is the same question patient would ask me: how many specialists who are experts in endometriosis? And it's really a big question, because now it says how many are there that now we can start going to the right guy. So for example, when I was a general gynecologist, which without much experience on endometriosis, I still felt that either I didn't know endometriosis existed or I did not understand endometriosis like I understand today. And I'm still not sure how I really responded to patient who came to me with endometriosis.
Yeah, so they're not wrong. They're not wrong.
So
they're not wrong.
They
They have
just
no.
don't know.
It's they didn't know.
exactly.
So I mean, it's.
And this
it's
is
a
the challenge there. If
and-
you
and
don't
this is
know, refer.
This is a challenge here, and I think you're exactly right. So we have to look at it, and now how the concept now is actually changing, and you have to really look at it. Is it more within this ecosystem where we exist, or are we looking at a bigger problem, which is a health system? And now we talk about health system, we're talking about everybody who's in it, because and we will have to address how do we improve the health system that has to improve the care for endometriosis. And this has to be patient education, has to be the community, has to be the nurses, has to be the clinical officers, has to be the medical officers, has to be the gynecologist. I mean, name it. If you actually now look at this holistically, it's now will start making sense. And I think there's a conversation I was having with you earlier, because trust you me, before some of these patients, let's say, for example, the county that I come from in Kirinyaga, I'll say it's how many gynecologists are there? I think we're less than 10 gynecologists. Now, what access do these patients have to somebody who can direct them to the, to the right direction? Now, having that withstanding, Yamal and myself and the rest of us who are really passionate about endometriosis and care for endometriosis now go surgical care for endometriosis. Artie, It is not you just don't wake up and you find yourself, you're actually excising endometriosis, excising bowel nodule. It's a very vigorous, tedious, and journey, and it can be long, and it really takes a lot of passion to it. So it makes it altogether a very difficult phenomenon. So how then can we improve? Then we really need to bring everybody on the table. Okay, fine, let's talk to the gynecologist, but then not every gynecologist will be interested in endometriosis. So then how we do? Okay, when we talk about referral, are we just referring? When we talk about referral, are we only looking at only one stakeholder who is a gynecologist who's keen? Or are we looking at a gynecologist who has infrastructure that, we've talked about the, ultrasound scan. I mean, the ultrasound scan machine that we really use for, giving us detailed imaging for endometriosis. It's just not a cheap, ultrasound scan. It's a really advanced device because then, really improves on the quality of the image and penetration and delineating the tissue, because that's very important. So I think this conversation should be done with a broader perspective. Where are the challenges? What are the blocks that we need to move? But if we only have this conversation amongst ourselves or amongst gynecologists, then we are really losing it. So it has to start from the ground, that if that clinical officer, that lady from Marsabit goes to, is well informed that, hey, guess what? This sounds like endometriosis. So what is endometriosis? Now that's where the conversation starts. What do I need to do? I think you need to have an ultrasound scan. And if we can have a single center that is in Marsabit, that please go, and there's a guy, only one who can actually do ultrasound scan. And then now we improve on the referral system. The same way we have referral system from a level 1, level 2, level 3, level 4, level 5, level 6. Exactly the same thing that we should actually be talking. And this is, I think, what is going to really bring changes in care for endometriosis. Otherwise, I really see a bigger problem because, I thank God that, I trained under Yamal, and I remember from the first day I met him, he talked about endometriosis, and I didn't know really the extent of endometriosis because, I was still doing, performing open surgery until now we start, digging deep into it, and, it's really starting seeing the extent of endometriosis. I say, oh my goodness, this is really exactly what it is. And it's not for the faint heart. It isn't. The moment you're getting, for the...
Us, we're the ones who live with it. It's not for the
It
faint-hearted.
really isn't.
So my question there, if you want to improve overall care for endometriosis in any society, the society could be a region, could be a city, could be a country, could be a continent, could be the world. If you want to improve care, let's first understand who are our stakeholders. So number one, stakeholders, because this is a complex scenario, is the patients themselves. So how do we involve the patients, improve awareness, and educate them?
Absolutely.
When you do that, they'll ask for their rights and they'll start looking for the right places. So that's number one. Number two, healthcare systems. So healthcare providers improve their knowledge and understanding of the disease. It's a complex disease. It's very difficult to understand. And trust me, when we train and come out, we are not expected to know everything. We are not. So train them, understand, make them understand. So that's second group. Third group is the diagnostic team. So improve the diagnostic team all over. You cannot have a centralized diagnostic team sitting in Nairobi, 3 people who do endometriosis scans, and expect the whole of Kenya to come there. It doesn't work. All right. It's just humanly not possible to do that. That's overwhelming. And number 2, that is selfish.
Absolutely.
So what we want is diversify diagnostic centers, as he said. I mean, have one in Marsabit, have 2, 3 in Mombasa, have some in Kisumu, so it means we are training these people to diagnose this better. Then the treatment centers. So you've now gotten a diagnosis, you've done a proper staging. Now, where do these guys go? So they go to specific centers that deal with these things on a day-to-day basis.
Absolutely.
As a multidisciplinary team. Finally, you cannot have a stakeholder that is not the government. All right. If this government is not going to help us develop policies of referral, policies of management of these women and girls, policies of what should be done so that we don't stigmatize this disease, it will not work. Finally,
help with
insurance
accessi-
providers. All right. Trust me, if they think endometriosis management is as simple as an ovarian cyst, it's wrong. This is very complex surgery and it's likely to be more expensive. So can they be involved in the development of protocols and policies around endometriosis and say, this is probably, if you get diagnosed endometriosis, then your premium goes slightly up and you may get people who would be willing to pay the additional premium just in case their daughter gets endometriosis in the future. And
Absolutely.
they're covered. It's a win-win for both. The
Absolutely.
insurance gets a little bit heavier premium for those who might be covered for endometriosis, but they are covered. So listen, if we don't do it this way, trust
not
me,
gonna
it's not going to work.
No,
Two people sitting in Nairobi making noise about endometriosis is not going to help the Kenya.
No.
It's not going to help the country. So
No.
we want to diversify the
Yeah,
care that is needed.
because it
Alright.
is a very,
So that's the only way.
yeah,
That's
it's
the
in a
only way.
very expensive
Yeah.
disease, you know? Apart from just the medication of it,
Oh, yeah,
even
yeah,
accessibility,
everything.
you know?
Everything. You don't
So-
expect someone from there come to fly all over here just for a diagnostic scan.
Imagine that.
It beats the purpose.
No,
Yeah,
absolutely,
it beats the
absolutely.
purpose.
Fine, so we're going to take a few more from online. We have quite a few questions and we'll see if we have our in-house have been patiently waiting as well. So Ruth asks, good afternoon. Can endometrioma begin to shrink on its own? Is Visan a viable treatment option prior to surgery? Can endometriosis form on the skin and mistaken for eczema?
Yes, I think I can take that. Endometriomas are pseudocysts. They are not true cysts. They are invaginations and then they collect. And that is because they have endometrium-like lining, which is actually bleeding every month when they have their periods, and it keeps on collecting, and that becomes, it gets the fluid from there gets sucked up, the water, and it leaves behind very concentrated blood products which what gives it the chocolate color. Now, you don't expect these to disappear on their own. A little bit reduction and increase in size can happen when there is an acute bleed in it. It grows bigger and then it gets shrunken because you have stopped it, and you could use some medication to help with shrinking it. But trust me, they'll never go away. So the way to have them go away could be actually if you remove the whole lining cell or you destroy the lining cell. And there are risks with that as well. You reduce the ovarian reserve of such women. And if they are considering fertility, then that is a challenge. But if done well, meticulously, that could be an option. So Visan, medications can all be used to suppress endometriosis, might shrink the size a little bit and the patient gets happy. But trust me, it's not going to go away with that. So I don't think that's a solution that's viable. And in the long run, endometriosis, if it is going to affect your quality of life, will eventually need some form of excision of those lesions. So that's my answer to that question.
Well, when we talk of endometrioma, I think Yamal has covered it. And there was a question on Visan, I think, in relationship to the question. And I think I tend to feel that Visan is, it's a hormonal treatment that sometimes get overused, in my opinion. And the reason I say this is because it's substituted to possibly inefficient expertise. So I would possibly throw the question back to myself. What would Visan do to a 7-centimeter endometrioma? Really, I mean, I really,
answer that for you.
well,
Nothing but really bad side
I really
effects.
don't see much effect. What will Visan do to 5 centimeter rectal nodule.
Mm,
We understand that in endometriosis, there's room for medical treatment, but
Mhm.
then it has to be well, stipulated that
Right.
this is the role for this reason and for this reason. Again, there are different protocols we follow for the management of endometrioma, just as Dr. Yamal has mentioned. And what I think to me is still very important is what the patient desire, and fertility is one of the things that we need to put consideration. So, are we just doing medical treatment for suppression, or are we delaying for pregnancy and so on? So, that has to be very clear. And this is where I kind of feel a little bit it's not right to where patients after endometriosis, VZ, endometriosis, Zoladex, endometriosis this. I think it's very important for us to be able to customize the treatment towards the patient. And I think it's long that we need to start stepping away from every patient who shows up for endometriosis is an endometriosis patient. We see them as endometriosis patient. I think that's really wrong. They have family, they have future desire, they have career, their quality of life is affected significantly different. And this patient needs to be offered as much information as possible, pros and the cons. And then with the information, then we are able to help the patient make an informed decision. So I would again say I wouldn't see what role that VZN has towards endometrioma and what is the expected outcome. So
I use medication. I mean, I'm not always pro-surgery. I have very many patients who are on medication, but as I've said, it's individualized, tailor-made to the patient's
Right.
preferences. So if the patient has certain preferences and medication comes in first, yes, it's an option. So we're not brushing aside that, but we are saying that it has to be tailor-made. You have to know everything about it, and then take a collective, conscious, and informed consent with the patient, and then work together in that direction. So that's very important. It's not something that should be thrown onto the patient. It's not something that the patient requests you to do. If the patient comes and tells me, I want the surgery, I don't have to do the surgery.
exactly.
So
Absolutely.
that's what I'm saying. It's not even patient driven. It's not even surgeon driven.
Mm,
It should be individualized, collective, understanding the pros and cons, and then decide.
mm.
Okay.
I was thrown with
I have a patient whom I've just seen 2 days ago who has a nodule in the rectum that eventually, and it's quite big, but she has no symptoms. She has no symptoms in the rectum. The symptom she has is a big nodule in the umbilicus that bleeds every month and is painful, and it's so I took her through everything. I've taken the staging. She's had a previous surgery for endometriosis, but the nodule is there. Now, the issue is we've agreed with her that we are going to tackle her current problem. And her current problem is this big nodule here. It's also a nodule in the umbilicus. We're going to have to excise that because it bleeds every month and it's painful like anything. So that's what we're targeting. And we've told her, listen, we'll keep on watching and observing your bowel nodule. The day we feel it's getting into a problem, it's giving you symptoms, then we'll go and tackle it if we have to. And you see what I'm saying? We saw it, it's big, we've measured it, but it's not causing any symptoms at the moment. Leave it.
Right.
So
right.
it's not, it should not be we are pro knives all the time.
Yeah.
That's a nodule. I'm telling you, it is, that surgery is being planned in the next few days,
Yeah.
but only for the umbilicus now.
Mm,
That's what we mean.
mm.
Treat the symptoms.
Yeah.
Treat
I
what-
was thrown with sun
yeah.
before I even got an endometriosis diagnosis.
Yes.
And it was just a trial and error back in the day because it just come out. And this is the thing with, as patients, the side effects, first of all, endometriosis is not only physical, emotional, and mental as well. the mental burden that it plays together with the side effects of the hormonal treatments, it's a joke, you know. But going into the hormonal, there's one question which I'm going to jump into because this is what we're discussing to do with Visan. And the question relies on another medication. Would you advocate for Lupron, and what are the adverse effects on a patient?
No, I think just let me say this, just to be very fair. In the management of endometriosis, I think it's important for us to say there's room for medical treatment, there's room for surgery, there's room for doing nothing, what we call expectant management. So, and this is what we need to really step away from, is feeling that one size fits all. That is actually not right. If you ask me, are there a point that you feel that there's role for GnRH agonists, the Zoladex, Leuproride, and so if you ask me, yes, there is. Is there a role for medication, you know, like Visane and progestin? And oh, absolutely, there is. But I think what I really would say, I would have hesitation, is to really say that this medication is specifically for this. So, for example, if you say Leuproride, I think for us who are in the industry, we would possibly say, I think you have one of the two. You either have fibroids or you have endometriosis, most likely endometriosis. And this is a thing that this is something that we really need to start stepping away from, whereby we can say, okay, we hear certain drug, okay, fine, I think this is it. Or hear this symptoms, then or automatically, even before the patient is finished saying, oh, I'm having painful menses. Okay, fine. Painful menses, endometriosis, Visane, and or whatever. So I think it's just fair for us to say there's role for different option of treatment. There's role for medical treatment. There's role for surgery. There's role for fertility treatment. It only has to be tailored towards specific patients.
Yes. So for Lupron, I think because of that question, Lupron is a type of a drug that we call the GnRH analog. So that's the group. How it works is it tries and suppresses some hormones and creates what is called a pseudomenopause. So it creates a menopause-like environment because it has been theorized that with menopause, the estrogen disappears, and because endometriosis is estrogen dependent, when estrogen disappears, endometriosis is gone. So that's how it is used. It is true, but with that menopause medication given to a 28-year-old, imagine the side effects that patient is going to go through when they have hot flushes, mood swings, sleep issues, no periods, issues with the bone getting weak, issues with the cardiovascular protection going away. So that is the problem. And therefore, that drug cannot come in for long-term use. If at all, it has some role, we can use it in certain scenarios. We're not discussing every aspect right now, but it is temporary. And one straight fact about that is it cannot be used longer than 6 months at a go. So what's the point of taking that right now? And in 6 months, you'll have to stop it and back to square one. So that's what we have to think. So there is a role, but these are the side effects. And the major ones we're worried about is the ones on the bone, because those could not be reversible. The others could be reversible. The hot flushes might go away, but the bone brittleness and the bone density dropping is likely not to be reversible. So you don't want these young women getting brittle bones and issues related to that.
And you see doctors as yourself, you suggest and you say you give options to also counter those side effects.
Yes. So
there are not many doctors who calcium.
With an add back.
Exactly.
It's called an add back therapy.
Right.
So if you have to use it longer in some people, we give it with add back. Otherwise, there's a problem.
Right. And unfortunately, not everyone can afford excision surgery. So
we
have to do options. Fine. Okay, I'm going to ask one more question from here. We do have quite a few, and then we can take our inpatient question. Is hydrosalpinx caused by endometriosis, what's the management?
So hydrosalpinx means collection of fluid in the tubes. Now, tubes are supposed to be open. So if it is an open tube, it cannot form a hydrosalpinx. So if it gets blocked, then fluid collects in this tube and it becomes a hydrosalpinx. So can hydrosalpinx be caused by endometriosis? Very yes, very commonly yes. Why? Because endometriosis causes extreme adhesions and it masses everything up and causes them to stick together. It causes lesions and growths and nodules and fibrosis around it, and it blocks the tube and the fluid collects in the tube. So if there is a hydrosalpinx, one, fertility is compromised severely. Two, pain is definitely there because it's a big mass that now collects around the ovary. So in most cases of hydrosalpinx, the treatment would have to be some surgical aspect and that tube would have to go. It's not likely to try and save that tube because a tube that is collecting fluid will be damaged from the inside as well. So just opening it, we could open it, but opening it is not going to be worth it because a tube inside and the fimbrial end, that's the thread that picks the egg, this would be eaten up in hydrosalpinx. And the tube inside has these small hair-like structures called cilia. The hydrosalpinx fluid that is this way would eat up the hair. So even if you open it up, this tube remains like a pipe. It's an open pipe that has no way of transporting this egg through to this side. So if it can't transport it and you get pregnant, it will be an ectopic for sure. So a hydrosalpinx actually is a very difficult tube to save. So that would be my advice, that those women who come with hydrosalpinx should be ready to consider that that tube might go. But with that tube going, frankly, we are going to improve their fertility significantly, maybe not naturally because their tube is damaged, but we are going to likely improve their fertility significantly by the IVF route. Because this hydrosalpinx fluid also, if it trickles down when there is a pregnancy going to put there, is going to destroy the pregnancy. So I tell my patients, with a hydrosalpinx, getting pregnant is almost impossible, both naturally or with IVF. With a hydrosalpinx removed, getting pregnant naturally is still impossible, but getting pregnant by IVF has jumped up many folds. So let's look at it that way, right? How do we help these women if they're coming for fertility with hydrosalpinx, get that tube out, and then consider fertility? Okay.
Let's take a question from our audience here.
Okay, thank you so much. So I've heard Dr. Yamal speaking about pregnancy. My question goes, does getting pregnant cure endometriosis?
Does getting pregnant cure endometriosis? You want to take that?
Well, honestly, I don't know how many times I get.
I know why you are asking before he answers
Yeah,
it.
yeah,
That is a major advice given out there.
yeah.
To
Get
every
pregnant,
patient.
endometriosis will go. Right? So I think it's important for us to answer that.
Well, I think I'll first answer that question and maybe explain a little bit. If endometriosis cures, if getting pregnant cures endometriosis, an answer to that is a big no. Absolutely not. And I think this is a myth. Now, this is exactly what happens. So patient has symptoms for endometriosis. And remember, when we were discussing the medical treatment, we said there's pseudo pregnancy kind of medication and there's pseudo menopause kind of medication. So the progesterone medication kind of mimic the pregnancy. So what will happen is that let's say, in circumstances that the endometriosis is not advanced enough to affect fertility, because we know that in advanced disease, just like what Yamal just explained when he was explaining the hydrosalpinx, is you find that there's adhesions, tissue stuck together, the ovary, the fallopian tube. So in the first place, this patient is not going to get pregnant. How are they going to get pregnant? Whereas their reproductive organs greatly affected. We've also seen patients where they have, advanced endometriosis, fallopian tubes are affected, and their fertility is greatly affected. So in first place, these are patients that you tell them, go and try to get pregnant. They cannot get pregnant in the first place because they have severe disease. So now you can imagine how frustrating that really is. Now, let's say we have the other counterpart that at least their disease is not advanced, their fertility is not significantly affected. Yes, they get pregnant. And now this is usually the trick, is that during this period when patients get pregnant, they will, in most cases, not experience the symptoms because their menses have been suppressed circumstances. But this is what then we get. 6 months after delivery, they'll come back and they'll state, my symptoms are bad. Now, I have a patient, she's 19 years old, typical symptoms, well, endometriosis, because then we operated on her later. So had symptoms typical for endometriosis, and this is really has a long, career in front of her. Goes and sees a healthcare worker and say, oh, fine, you have pain. This pain is cured by getting pregnant. So she definitely gets pregnant. Guess what? Surprise, surprise, surprise. 6 months down the line, now the symptoms are back, even possibly worse than they were. Can you imagine what really goes in this young girl's mind? She has a child that she had not planned for, and she has a child who is a result of treatment for endometriosis, which now she has treatment that did not work, with no responsibility, and still with endometriosis. I mean, come on. I don't know if, this can get worse than it is. So if you're being prescribed a prescription and patient, will get this, oh, go get pregnant, it's going to get better. It's no, absolutely no. Pregnancy does not cure endometriosis. Well, there's no cure for endometriosis for a fact, but it does not improve endometriosis at all. So it only alters the symptoms of that period that the patient is pregnant. And actually, as a matter of fact, a patient who will have endometriosis or even say adenomyosis, they might have a very difficult period of their pregnancy. Because the pregnancy, so it has to be very well determined that it really doesn't. I don't know.
Doc?
Yeah. I mean,
Good.
agreed. Pregnancy, if they are planning to get pregnant, you tell them, please go ahead.
Absolutely.
It will improve your symptoms. Okay, if you get pregnant. If they don't get pregnant, also help them to get pregnant. Give them medication or whatever necessary to assist with the pregnancy. If that works and they get pregnant, they will see an improvement for the 9 months and for a few months while they're breastfeeding. But trust me, after that, it is going to come back. So they should be informed about that so that they are aware that right now it's like a halt of my symptoms and an improvement of my symptoms, but it's not a cure of my disease. I still have endometriosis and it's likely to flare up again later after the delivery. That should be clearly mentioned to the patient. That's all.
Right.
Maybe again, beyond this, it's also important when we see patient with endometriosis, because we know the symptoms for endometriosis, well, the effect of endometriosis is fertility and quality of life. I think it's also, depending on what we see and what we find and the effect of endometriosis. So let's say, for example, a patient has endometriosis of the ovary, not as treatment, but then when you start having conversation, I think it's also important to put everything on table. How is your fertility going to look like? What are some of the effects that could happen? And then with all that information, then the decision is really,
Very, very important. We have another question.
Yes.
So I'd like to ask about how extensive can endometriosis be in the aspects of its sites in the body, and what are the complications if endometriosis is left untreated?
Thank you. Very simple answers.
Hmm.
How extensive can it be? Anywhere and anywhere in the body. We've seen endometriosis in the eye, in the brain, in the nose, in the throat, in the breast, in the abdomen, so anywhere. In the liver, in the liver, in the intestines, we know. All right. So basically, I think in the nails. I kid you not. Here, we've seen them. Okay. So every month, this area starts bleeding during periods. So in regards to where, anything and everywhere. All right. You know about the bladder, the urinary system. So anywhere. I don't think there's any space that I can say can be free from possible endometriosis. Okay. Lungs we have seen, diaphragm we have seen. So that's a simple answer, anything. But those are very rare scenarios. So we go on percentages of which areas are more frequently affected. But in regards to what can be affected, it's anywhere. Okay. In regards to what will happen if endometriosis can be left untreated, it depends on the location, right? So location like in the bowel, if it proceeds and it gets worse and it gets bigger over time and it infiltrates further, it will eventually cause a block. If it causes a block, that can be life-threatening because this is not a block that you can easily remove, right? So imagine a block not being able to go to pass stool because initially we'll start with, we've had an operation we've done for some patient like that. That she would only pass out pellets like the way a goat does, you know, those small pellets. And you wonder because she can't pass stool well, okay? And it will reach a point where now she's busy throwing up everything. She starts losing weight, she can't eat, and that can be life-threatening. Second thing, the ureters are frequently compressed, and if that is untreated, that means silent kidney loss. And it's been found that that happens in 11 to 15% of women with deep endometriosis. 11 to 15% of women undergoing a kidney loss and a kidney failure. I mean, come on, that's not a small thing. That's a dangerous side effect to be waiting for. If it's in the lung and it starts bleeding, you're bleeding into your lung and coughing out blood and coughing, I mean, come on, that's life-threatening. So what I'm trying to tell you is that what happens if not treated depends on where it's affecting. So there's some areas when affected can become sort of an emergency. You don't play around with the ureter that you see it's swelling up. That becomes an emergency. That patient needs surgery quickly, otherwise she loses the kidney. Got it? But those are in those extreme cases. Another case, untreated, there might be a slight increased risk of certain kinds of malignant transformation and certain kinds of ovarian cancers that develop in that kind of a endometriotic abdomen. One I closely remember is just 2-3 months ago. A patient who's had endometriosis and we've been planning treatment and possible surgery. And I don't know whether it was originally starting that way or it transformed later. It's difficult to say. But we knew that that had endometriosis in the ovaries. We could see the cyst. And now, the last time we saw her, these things had grown up. And we started seeing suspicious features. And the patient went in and had some confirmation biopsies taken, and that was a cancer in the ovary. So that is another likelihood of all those kind of endometriosis untreated. Okay.
We have another question.
Yes.
Question is that what
Options do we have for treatment of endometriosis? And according to you, what is the best option for the treatment? Like if we want to choose, so.
Well,
I said that was easy question. This
Yeah,
is difficult.
This is a
question,
difficult
all right?
question.
Because there is no standard answer to that.
Yeah.
I mean, we'll just cover it briefly, but trust me, that's not an easy question to answer.
I think just to put it clearly, there's no standard treatment
Or
for
best treatment.
No, I mean, you cannot really say, but it's so important to say the gold standard for the management of endometriosis is eradicating the endometriosis. So for instance, if it's a nodule, whatever, cutting it out. Now, when we talk about eradicating, so again, we have to be very specific because not every patient will be fit for surgery or will benefit from surgery. So again, as we said earlier, is surgery should be preserved for certain patients. There's also going to be certain, situation whereby you'll find patient has really advanced disease. I mean, Dr. Yamal was talking about different organs being affected. So it has to be a balance between how extensive you need to be and how much do you preserve the function of the organ. So it's really a balance. We talked about medical treatment. Some patient might respond to medical treatment, others might not respond to medical treatment. At what severity, degree, what is the patient preference? What have they tried before? What have they not tried before? What is their, immediate goal? What is their objective? So there's a lot of variables we need to put in consideration. So you need to listen to the patient. And this is what we were saying. It's wrong to say that endometriosis, drug A, endometriosis, drug B, endometriosis, surgery. That is really wrong way of looking at it. So you need to have a conversation. Listen to the patients, and make a decision. What would benefit the patient, not what do they require, is what is going to benefit them. So there are no protocols that will say surgery is for this and this and this, medical treatment is for this and this and this. So it's a very wide factors that you need to put all them together and really find what will be the best option for the patient. Sometimes we have to tell the patient, these are the options, please go think about it and, seek a second opinion. Let's have a discussion. Patient will have, some patient, you start them on medical treatment and immediately they've solved their first, tablet or whatever, they have a really terrible side effect. So then you have to change, they try something different. Some are not willing. There's a lot of myth surrounding hormonal treatments. Oh, no. Anything to do with medical treatment, tell me anything else, but don't tell me about medical treatment. And they're willing to, have surgery other than them trying, hormonal medical treatment. So it's a very difficult way to look at it.
So my few points there. I think, being a teacher, I like putting things simple and straight for people to understand, because it's a very complex discussion. I told you it's a very difficult question. But my few points. Number one, patient preference based, individualized, tailor-made. Number three, could be medical, could be expectant, could be surgical. If it is surgical, laparoscopy over laparotomy. These are dictums. I'm not going to change there. Laparoscopy over an open surgery. Okay. If it is going to be surgery, excision over ablation. So these are dictums that I will not change. But I cannot tell you this for this patient. You've understood. But these are very specific dictums. Excision over ablation. Don't destroy, excise. Remove it from the root. Don't slash it like a weed. Okay. Another rule, if it is medical, then the medical hormonal treatment that suppresses her symptoms best. The medical hormonal treatment that gives us the maximum period-free interval, because period-free intervals actually improve symptoms. So if you use the pill, combined pill, we use it in a continuous fashion and they get period-free intervals longer, then it improves the symptoms. So you look at like side effects are few and they get a period-free interval that is long, it improves them. So these are some dictums that I think I can mention about treatment, but there is no one specific treatment for. Okay.
Thank you. It's already 5:36. We've done a lot. We've got a few more questions. Well, we've got quite a few questions online as well. A follow-up to what she just asked, because this is a question there, which is interesting.
One more point.
Sure.
Before I add, again, in treatment, first surgery should be the best surgery.
Absolutely.
No dictums. Those are dictums that I cannot change. First surgery, these repeat surgery issues is not a good thing. I'm not saying it can never happen, but we should minimize repeat surgeries.
And another point to that, there is no ablation. Ablation should be out the window. Ablation should just not exist, period, in the whole world. Sorry, but yeah. Okay, we have a question saying, can you have operation of endo and it's done?
Yes,
As you said, your first surgery should be your last surgery.
yes. Why
Do you want
not?
to elaborate on that? Or are you good?
No, with good excision surgery, it's possible. We can never guarantee a recurrence-free period, but with good excision surgery, it's very, very likely if the patient's goal was, let's say, pain, then it's very likely to prevent this recurrence even forever with suppressive therapy.
Right.
So it's possible that a good excision surgery can actually relieve our symptoms probably for life.
Also,
So that's
again, early diagnosis,
Yes,
no
yes,
progression, all those.
Possible.
I'm a doctor. As a patient, no, I'm kidding. Okay, we have, well, what causes endometriosis? What causes relapse of polyps? That is after polypectomy.
Well, I think possibly that will be a totally different topic, you know.
Absolutely.
polyps. And,
Yeah.
you know, it's a very different topic, which maybe one of these days we should handle. But I think Yamal we had discussed what causes endometriosis, you know, very clear recurrence. Again, since we don't understand how it develops, when we manage endometriosis, you know, we really not altered the development, possibly progression, but then there are things that we can slow down, and this is what exactly we are discussing now.
Yeah, polyps, I mean, we can't say recurrence of polyps. I'll just answer because they've asked, but a polyp is just an overgrowth of the endometrial lining. So it's like a skin tag that we sometimes get hanging over the skin. That's an overgrowth of the skin. So similarly, you can get an overgrowth of the skin tag, and it can, if it formed once, it can form again. I mean, that's not something you can prevent forever. But one of the things I like mentioning is many times, if you don't get a polyp out from the base where it starts, if you just cut it here, this will regrow. So you may need to go to the base of the polyp and remove it, as opposed to just cutting it. If you cut it, it will recur faster. It doesn't mean if you cut it at the base, it can never happen, but you might delay when it will happen. And same with endometriosis, many cases of recurrences actually, not all, but many cases of recurrences actually can be not cases of recurrence, but cases of probably incomplete resection. So if there's incomplete resection, then the disease obviously comes back faster, or your symptoms come back faster. And if it is excised properly, then you can delay the recurrence, but you can never prevent it.
Which is a very, very important point that you made there. So thank you, Doc. All right, we've got another question that says, does endometriosis have any relation to a tilted uterus? And if after 5D and Cs, your endometriosis is still debilitating, what next?
Well, I say yes. I don't know what it exactly means by tilting the uterus.
But it's
Yeah.
twisted.
Yeah, so,
Tilting,
tilted is-
retroverted, twisting
Yeah.
the axis. Endometriosis can do all that anyway. So it could be that. And if they've had recurrent miscarriages, I'm not sure it might be only endometriosis, because endometriosis makes it difficult to get pregnant. But once pregnant, the pregnancies can be difficult, but they don't usually end up with losses. So look up causes of recurrent pregnancy loss. There might be something causing that there. And if at all it is related around endometriosis, then it could be adenomyosis, because adenomyosis is known to mess pregnancies up
Right.
and cause miscarriages. So I don't know. You want to add something there?
no, I think basically adenomyosis is more notorious. It should
Yeah.
be
For pregnancy.
right.
Right. So S has a follow-up question. She said, thank you for your answers. And what happens when Lupride Zoladex fails to suppress? Is there more superior medication? I think she's asking because of inaccessibility to excision or also fundings.
I think it even when you talk about medical treatments, I'm not sure if I'll be correct to say that GnRH analogs would be superior to what superiority exactly are we looking at here? Is it suppression? Is it a side effect, and so on and so forth? Actually, the literature is actually shown that some of the progestin would give more or less the same effect as a GnRH agonist. Why so? The GnRH agonists, remember we say that they have limited period that you can use them for. And how much substantial suppression you get from, 6 months use of GnRH agonist is still again something that is quite debatable. So you could find that someone who has been on progesterone for, they are okay with symptoms, their side effect is tolerable, and so on and so forth. As a matter of fact, you could find patients who have, not responded to GnRH agonist, and then they're downgraded to, medication like progestin and so on. So I think when we talk, we talk about, the first, line, the second line, and so on and so forth. But again, as we keep saying here, it's whereby, the question comes in as, I started with COC, I go to, progestin, whatever, then I go to Zoladex, then it's something else. Again, let it be very clear, very, very clear, that in most cases, as much as our aim is to have suppression from medical treatment, in certain circumstances, you might not really get much effect from the medical treatment. And excision might be possibly the treatment of option. Why do I say this? So again, if the example that, Dr. Yamal gave, a patient who has a bowel nodule, which is like 5 centimeters or whatever, and so on, would you really be keen to give GnRH agonists to suppress? Possibly it might not have a role. And the moment this patient start having symptoms, would you be quick to give medical treatment? Possibly not. Excision then now becomes a role, because now the moment you start getting symptoms from obstruction of the bowel and so on and so forth, you literally need to go in and get it out. So what am I saying? What I'm saying is that if medical treatment, whatever, is not working, possibly then you might find excision might be the option. But just to be clear, I don't think we would say there's medication that is superior than, GnRH agonists. And talking about superiority in medical treatment, I think it's also not the right analogy to use, that this is superior to this. You try this doesn't work, then you go to the next, then, So it's really many factors, again, as you're saying, what is really responding to the patient? What is your main aim? What are you targeting? Are you really targeting to suppress a nodule that is 5 centimeters to 2 centimeters? What is your objective? How do you follow? Do you follow with ultrasound? Is it happening?
It's not happening. So if it's not going to happen with progesterone, possibly it's not going to happen with Zoladex.
Dr. Yamal, you good?
Yes, yes,
Okay, we've got 15 minutes.
yes.
There are a few comments that I'm gonna read through, and then we do have some important questions, which one I really wanna ask because I suffer from that as well. Dr. Shilpa from India says completely with you, Arti, on this. I think it's regarding a statement that we had made. There's one saying, these are really great doctors. Dr. Njagi really handled us well. The laparoscopy surgery went well with us. Much appreciation to you, Dr. Ari. This is from Collins Ayo.
It's a pleasure.
Then, okay, there's a question regarding insurance, which I'll get back to. This is another, Harveen says, hello, mine is not a question. It's a congratulatory message, especially to Dr. Yamal. He saved my life twice, thrice, if you count his referral to a support group to help with the mental and emotional side of things. So these comments get me emotional when I read stuff like this. So I just want to take a moment to congratulate Dr. Yamal and Dr. Njagi for setting up the first endo center in the region. It's a proud moment, especially as an endo patient, to see all they are doing to advance endo care in Kenya medically through awareness and advocating for changes in the medical industry. Thank you. There's another one that says, I'm very proud of this is Sophia Munene. I'm very proud of Dr. Njagi and Dr. Yamal. They are taking a road never traveled before to bring awareness to women about endometriosis. This area has received minimal attention in the past, yet so many women are suffering from endo. So thank you, docs. The impact that both of you make is, trust me, it's bigger than an earthquake. So thank you. Okay, well, I will go back to questions. We'll try and answer them as short and possibly direct as possible. There is one, I don't know how short and direct this one will be. About insurance. How can you doctors collaborate with insurances to incorporate endo treatment? Third Park Hospital, being one of the major endo center, is not recognized by many insurances.
And I mean, short answer, it's beyond us. These are policymaker issues, and it's very difficult. And we are going to help probably by creating more awareness. And I think, how can insurance companies help? I mentioned earlier, take them as a special group and consider giving them a higher premium to include that in future. Obviously, I know I'm not saying include them once they're already diagnosed with it, because they call it pre-existing. But when they're going in, and you know the way we say when you're taking insurance, they say we have riot cover, we have fire cover, we have some earthquake cover, natural calamities, and when you keep on adding these covers, you keep on adding your premiums. Let them have. We have maternity cover, and they have some maternity, some without maternity. Let endo be one of that. It's an option. All right. I mean, insurance, you shouldn't just say no, and these women are suffering, and now they don't know what to do. They can afford it. They've been paying insurances premium for the last 5-10 years. And when it comes to now requiring treatment, they say that's not covered. I mean, it's not right. So I believe it's beyond us, except by creating more awareness, and then eventually it will fall into place probably. Like infertility and IVF is not covered, but there are certain countries that cover it, and they just take an additional premium from them, and they say, okay, we'll cover your first IVF. I mean, you get what I'm saying? There's always a way out. But it's not for me to do that. This is policymakers. I'm too small a fish in that field. Let them decide. But I think they should sit down with stakeholders and decide how to do this.
Absolutely.
That's the way forward.
And the thought has come into my head that, you know how a lot of patients say, but doctors don't take this, insurance don't take. I agree with you that it's not a fight for you guys to do, because it's the policymakers that need to do it. Do we as patients want our doctors battling the insurance
It's a challenge.
or taking care of us,
That's true. I mean,
Exactly.
it's very difficult.
because it's
Very difficult,
challenging.
yeah.
I rather my doctor focuses on me than, I mean, wasting your time fighting heads over insurance companies where it's the policymakers who have the upper hand.
You know, RT,
It's not that we don't want. I mean,
And of
this
course,
is my passion.
absolutely.
And
We can
those who
see it.
know us too, we've probably done over 800 surgeries free of cost in our Mashinani area.
Absolutely.
Free of cost, we don't charge. It's not the money.
It's not.
But listen, guys, I mean, it doesn't also mean that everybody can be done free. I mean, that's also impossible. So we have our challenges, but if we sit down, there's always a solution. There's no problem on face of earth that has no solution. It's only to sit down and find a solution. I mean, that's what I would say.
yeah, no, and I think you're right. Part of, you say, part of our alibi is just excellent care. And I think with all these challenges that, you know, and I think whoever asked the question, we keep facing, it has not affected the quality of care that we still advocate for. That is our main objective. So I think you put it right. We have put it right here. It is the patient who will demand, as you know, paying a premium is us to set the standards. That this is the standard of care that, you know, we've set, and I think that is non-negotiable. With or without it, is we are setting the standard. I think it will be great to have the stakeholders, insurance come on board, but RT, it's a matter of time. You can only ignore enough. What really kind of makes me sad, and this is, it really makes me sad. A patient come to me, first time, diagnosis, endometriosis, make a diagnosis, to have surgery, all right? So again, goes insurance says, no, we can only cover this in this hospital. First of all, I feel that is discriminatory. And he say, okay, unfortunately, I feel comfortable working on this setup is because it's me who understand endometriosis, and this is the infrastructure that for me, as your doctor, feels is what is appropriate for you. Unfortunately, I am not willing to compromise, because if I do that, most definitely I will compromise care for you. And the patient says, okay, no problem, goes back and decide it chooses to go. This is a real story. Exactly 6 months down the line, after the first surgery, comes back, do ultrasound scan, endometriosis is still there, it's looking at you, and it affects me. I'm human. And I say, I'm really sorry, but this is exactly what you're looking at. What are the options? The option will still remain the same option I gave you the first time. Goes back to the insurance and says, unfortunately, you don't cover. So what does that mean? It's
difficult.
It's difficult. It's difficult.
Absolutely.
So our responsibility,
Yeah.
how we see it, is we're not going to compromise on care that we give to the patient, period.
Absolutely.
With
Thank
or without
you.
insurance, we're not going to compromise. We're not going to lower the standard. I feel sorry. You go to, you know, next place where the insurance is
Absolutely.
covering and whatever, the, you know, compromise on standard. I feel sorry for the patient.
It's a tough call, definitely.
It's a tough call.
It is. There's another question. We have 5 more minutes, but I'm going to extend it for another 5 minutes because we started a bit slightly late, if that's okay. We do 10 more minutes, okay? Because everyone's just loving this, like the comments that we're getting, and it's very informative, but I know you've had a long day. But there are 2 questions that I'm going to integrate together because they're separate. Can both tubes be removed? Which is a very simple question. But this next one, which Mary asks, is very, very important. How does endometriosis affect the nerves, especially the sciatic nerve? And my addition to that question is how it impacts neuropathy. I live it, I face it, it's horrible.
Right. So can both tubes be removed? Yes, if they are damaged. And if they are both hydrosalpinxes, I told you, trying to salvage those may not be the best option. But it's a decision that we have to take collectively. If the patient says, no, try save my tube, then we try and save them. How functional they'll be after that is a difficult question to answer. So when we remove both tubes, again, getting pregnant naturally is close to zero, but getting pregnant by the IVF route still remains open. So yeah, I mean, it's okay to sometimes remove them if they're completely damaged. Regarding the nerve involvement, yes, the pelvis is actually the most complex part of the body, apart from the brain, in regards to nerves, because all the nerves come in that one pocket called the pelvis as they go down to the limbs and whatever. And they have small exit points to the bone that we call the pelvis. So it's very possible that this endometriosis that is forming nodules and growths and swellings and hard fibrosis and inflammation, it's not going to select what it's going to press and what it's going to involve. It could involve the bowel, it could involve the bladder, it could involve the uterus, the tubes, the ovaries. Now, these are the common ones we know. But it could also involve a vessel. It could involve the ureter that it's pressing. And now it could involve the nerves. And the nerves in the pelvis are very many, right? Very many. So sciatic is just one of those nerves. And the reason it's probably being marketed or being talked about here more is it's the biggest nerve in the body. So it's easy for the biggest nerve in the body to be compressed more, even by something small, than small nerves that can escape compression. That's the only thing. But it can actually affect any nerve. The common ones that we see in the pelvis that create massive symptoms are the pudendal nerve, the sciatic nerve, and then those others that are called the hypogastric nerves and the plexuses that they form. These are common involved. Peripheral nerves also can be involved.
Okay.
So pudendal is a peripheral nerve.
Okay, fine. Good.
Sciatic is a peripheral nerve,
Right.
but these are autonomic. So
Okay.
the autonomic ones impact function of organs like the bladder, the bowel, the rectum, the sexual function. So it impacts that. And the peripheral ones are the ones that affect sensation. So sensation is tingling, pain, nerve, pain, and restlessness, pins and needles. So that is now peripheral nerve.
Okay.
So yeah, if it impacts and presses on your sciatic nerve, it will cause significant sciatica pain. So
Yes.
unfortunately, if it starts involving that, then that nodule has to be lifted off that nerve. Otherwise, it won't improve.
Definitely.
And that component of surgery is extremely
Absolutely
difficult.
difficult.
Yeah.
Yeah, definitely. This was a question that was asked before. She's tapping on it again regarding the skin endometriosis. We can keep the questions short, answer short. Are there cases where endometriosis occurs on the skin, but diagnosed as eczema that flares during menstruation? How long does excision on endometrium provide relief for or chances of a repeat surgery? You touched on the latter, but I think it's the front.
Yeah, so I'd say the recurrence of endometrioma, we really can't tell. It's really variable. Do we find superficial endometriosis on the skin? About presentation as eczema, I don't know. I'll let Yamal answer this.
Yes, so it could. The key that is important there is it flares up during periods.
Exactly.
So that gives you, it's called catamenial. Anything that has a catamenial component, catamenial means flare up during periods. Anything that has catamenial symptoms has some endometriotic component to it most of the time. So if it has that feature, then yes. And I told you it can affect anywhere. I've seen one in the conjunctiva, in the eye. So every month she bleeds from the eye. All right. Now imagine it's such a rare thing, but you can imagine having something in the eye that only bleeds during your periods. So that is an endometriotic lesion. I mean, you don't need more proof than that. You get it? So it's very rare. So that is the key that she has, and it flares up during periods. And yes, it could be.
Yes, yes.
Latifa saying, can we have these discussions more often? They're really helpful. We will surely, but we're taking a lot of the doctor's time. Okay, doc, it's 6:02. I'm just gonna literally go into this. Just to let you know, also we have viewers joining from all over the parts of the world, not
Okay,
just
nice,
Kenya.
nice.
We have London, India. We have another one. I'm intending to come to Kenya for medical assistance. I'm in Uganda, and we don't really have much help. You're more than welcome to
You're
come.
more than welcome.
Thank you for such an interactive session and sharing your wealth and knowledge. How does one get in touch with the doctors? We will post. Right now, I can't type on this. Can you type?
No.
You've posted it? Okay, perfect. We've got, okay, we've got the Dr. Njagi and Dr. Yamal's Instagram pages on this, and you can send them a direct message. Can we have the doctor's contacts, please? Great, excellent discussion. Please share your handles. Great discussion, so helpful. Thank you.
It's a pleasure.
Thank you. Thank you. It's been a pleasure.
It's been a pleasure. Thank you so much. Thank you. We're good with all the questions. I think we've answered all the questions, even in person and online. First and foremost, thank you so much to our in-person patients and our online participants. It's been great. We've had a brilliant outcome, and a very, very big thank you to Dr. Yamal and
Thank you.
Dr. Njagi.
It's a
A
pleasure.
very big thank you to Third Park and our team, the crew, everybody who made this possible, and we're very, very grateful to both of you.
Thank
Thank
you.
you
Thank
so
you again.
much.
Thank you for the opportunity.
Thank you all and have a great evening.
All right, thanks, everybody.
Bye-bye.
Bye-bye.